Hi everyone, this is Mr. Neil Writer, also known as the Wax Whisperer. Thank you for tuning in to today's video. It's a very interesting case indeed. Had a patient who actually attended today. He attended with bilateral otitis externa. So otitis externa is the medical terminology used for an outer ear infection and or inflammation. The patient had been suffering from chronic otitis externa for the last 12 months now, and during that time they have visited their GP on numerous occasions and been prescribed oral antibiotics and also topical ear drops, but to no prevail. Around 2 months ago, the patient had used a cotton bud in the left ear. The patient felt as though at the time the cotton bud got lodged in the ear, but they weren't very sure because the ear was blocked anyway. And he came across me, he's heard about me, got recommended actually by another client of mine, and he attended today to see if I can help. So we're just in the left ear, and you can see the ear canal is extremely swollen. So when the medical term for swelling is edema, and we're kind of halfway in the ear canal, and the ear canal is extremely swollen, and we're just tugging away at this debris. And at this stage, I only found out about the cotton bud afterwards, and it was myself who prompted the patient, have you been using a cotton bud? Because it's becoming apparent that this is not debris, it's a piece of cotton wool fibre. And the patient reluctantly acknowledged at this stage that it is a cotton bud, and immediately I've gone in with some forceps because with cotton bud it's very difficult to suction that out. You have to grip onto it, and there we are, that's the cotton bud, and it's all layered and coated.
It's got the appearance of like some infected debris, but I think it is cotton wool, and it's the typical cotton bud, and it's almost kind of soaked all the discharge in a way. And it doesn't look like cotton anymore.
I've got both the live audio and myself narrating over, so I'm still working on how to best include and mix both types of audio, so do bear with me, still kind of learning curve. With the video editor that I'm using now, the new one, it doesn't tell me on the live video file when there is audio, where my previous one did, but there must be a way, so do bear with me. I'm sorry if you're hearing me twice there.
Brilliant, yeah, you will.
So that's the visualisation of the patient's eardrum. It appeared a bit dull, inferiorly at first, but performed a pressure test, and the middle ear is functioning fine, so there's no infection behind the eardrum. So it's just a bit of dead keratin on the eardrum. I'm just going to mop up now.
You may have an infection behind your eardrum as well, so we'll test for that in a moment. Let me just mop up near the entrance. Cat's penny too, when your ears are itchy, you want to scratch it, but it can actually make the situation worse. So again, I'll give you some
just using a fine end. So do stay tuned into the patient's right ear. That's the really interesting one. If this was interesting enough, you haven't seen anything yet, because the patient's right ear was extremely narrow. Probably the most narrowest ear I've had to perform a procedure in. So do stay tuned. So just some keratin here. So I'm going to use some forceps actually to kind of extract this. So the patient has also got otitis externa, the external kind of ear, what we call the pinna. This region here, just before the entrance, is called the cavum concha. So there is also otitis externa, so kind of an eczema inflammation infection of not only the ear canal but also the outer bowl of the ear. And that particular part was called the cavum concha. So the eardrum is fully visible, a bit of dead keratin there, that will naturally migrate. The patient was feeling over the moon after that procedure in the left ear. So now we come on to the right ear, and you can just see how narrow this right ear is, and I'm trying to stretch the ear open. It's very difficult. I just couldn't get the suction probe in. And we're using a fine end gauge. This is kind of probably the most smallest one we can use with enough adequate power for removing debris in the ear. But unless we persevered and I managed to gain access. And you can see in the background there some white otter ears. So otter ear is the medical name for ear discharging. So I'm just trying to clear the entrance so I can visually see that a bit better. And I've actually got the patient helping me slightly. I've asked the patient to, with their opposite hand, so this is the patient's right ear, I've asked the patient with the left hand to go around the back of the head and just pin the back, the external ear back, just to open it up. Now, that won't open up the ear in a two-thirds, the bony part, because that's not flexible, but it will open up the cartilaginous portion, the outer third, because that is flexible. And when you've got all this dry skin, discharge in the ear, at times, obviously it will be a bit blurred on screen. That's the nature of when you perform procedures of an infected ear. You can see I am managing just about to get through. Now we're in the bony part here, so even though we've managed to get through that one part of the procedure, the endoscope got kind of trapped inside the ear canal, and it was difficult to pull out because obviously we were expanding the ear canal ourselves using the instruments, and at one point the ear canal collapsed upon the endoscope and it was a bit of a tuggle to pull back out, but I managed to do it. You can see there's a lot of dead keratin at the roof of the ear canal and on the back part of the ear canal. This is the posterior part. I'm just trying to peel it, and as ever when you've got an infected ear, it's quite wet, a lot of sticky mushy debris, so it kept blocking my fine end board, so I had to come out of the ear quite a lot to unblock that, and I also had to wipe the camera lens, the tip of the endoscope, so I can get the best visualization in the ear. So just gently peeling this off the ear canal wall. And the patient could already hear significantly better, but the idea was when you've got an infected ear, I always try to remove as much debris, discharge, infection as is safely possible. That doesn't mean I'm going to ever remove everything, it's not possible, but the more removed, the better the chance the patient has to recover from this infection. Obviously, I've advised him, recommended to ENT consultants, because I think it's better the patient now sees the ENT. It's been chronic, he's been to the GP several times. There's nothing wrong with the GP is doing, but because it is chronic symptoms, I think he'd be best getting prescribed treatment from an ENT consultant. So we're just getting deeper in the ear now, and you can see there's a little fibre here, so I suspect the patient had also been using a bit of cotton wool in this ear, cotton bud tip, but the tip of the cotton bud didn't get trapped and stuck in the ear canal, just a few fibres. So it's a real strain to get the fine end gorge into the ear canal. Once we're halfway through, the ear canal does widen a bit, so there's a bit more manoeuvrability. But what is difficult in this procedure, you'll see it in a moment, near the anterior recess, so on the right hand side of the ear canal, deep near the eardrum, there was a bit of keratin there, and it was very difficult to get access to it because the ear canal is very swollen and inflamed and narrowed. If the ear canal is wider, I can adjust the angle I inserted the fine end gorge to get a grip onto the dead keratin. So we'll see it a bit later on in the procedure, but it's the keratin on the opposite side of the right hand side of the ear canal, a bit deeper. So I did bend the tip of the fine end a bit later on just to get access into there, and because the ear canal is quite inflamed, so you don't have that ability to manoeuvre the instruments around in the ear,
it might be a bit tender, I can't help
as you would in a normal ear.
It's really uncomfortable, do let me know. Yeah, I've got something there. Discharge.
The patient experienced a lot of relief when I removed that particular piece of debris. So you can see the ear canal's closing up now. The longer in the ear now, the more swollen it is going to get, so I'm just trying to get as much out as possible, the main bulk first, and then once I've got the main body of debris out, I can then go back in and mop up if I need to. At the moment, the priority is just to kind of visualise the eardrum, and that's why we're trying to just go straight down the middle towards the eardrum and just create a pathway so air and sound can travel through the ear canal towards the eardrum. So we're near the eardrum now, so we're just at the inferior recess, just trying to peel some skin, but the eardrum is in view now. You can just see the handle of Mandy's.
Just about to your eardrum, although it's very mucky in there.
Vertical structure.
I think we've done a good
there is
job.
Keratin superiorly to the roof and
if I can get any more, but
anteriorly to the right. And that was a great perspective. You can see now just how narrow the ear canal is and how deep we're having to go in. So it's just some debris there.
Blocking the tube, so I keep having to come out. And not a problem.
So if this is the first time you're watching on YouTube, please do feel free to subscribe to the channel, select the bell icon so you get notified as and when I upload new videos. Similarly, if you're watching on Facebook or Instagram, please do follow the page. Feel free to leave a comment on the video as well. And if you enjoy the video, do make sure you do like it as well.
Yeah, I can really see your eardrum.
So you've got a good view there of the eardrum, and you've got some keratin, some dead skin on the roof of the ear canal. That was what I was referring to earlier, and it's difficult to get access to that. So I'm not able to insert the endoscope any further in the ear canal there. That's as far as I can go because the ear canal itself, because the swelling won't allow it. We do have to be very gentle in this, well, anyone's ear, but more so this patient, because the ear is obviously infected. It's tender. The patient was reporting ear pain upon attending the appointment as well. So we've always got to be gentle and delicate when we remove wax or whenever we're in the ear. That's not just for an infected ear, for anyone's ear. We don't want to cause them any distress or pain. So. I was asking the patient, who may have heard me several times during the procedure, if they're feeling okay, if it's comfortable, and if it's painful to please do let me know. But the patient was fine throughout. So this is the anterior recess, and that's that dead keratin. So I have bent the tip of the fine end, so I can just manoeuvre it and gain access around the bend of the ear canal. It's really peculiar. I've had loads of complex ear infections recently. I think that's part of the territories. A lot of these patients find me on YouTube, so they've seen some of my past procedures and think, well, okay, let's book in with myself. More very ironically or coincidentally, or I'm not sure, but a lot of the patients who have severe infections like this gentleman did often attend on a Friday, and they often are the last appointment of the day, which is actually benefits me fine, because it allows me more time with the procedure. So whenever I book an appointment in with a patient, we allocate half an hour. That half an hour is whether we perform a procedure in one ear or both ears. A lot of time patients are not aware whether they've got wax in one ear or both ears, so it's always best to have that half an hour because I don't want to rush. Obviously many patients are travelling a long way to see me now, so I want to give them allocate enough time so I can treat them adequately. So and quite often I'm finished within 3 or 4 minutes, but procedures like this, it's always handy to have this extra time.
You feeling okay?
Hey?
Are you feeling okay?
Yeah, fine.
So we're nearing the end of the procedures now. Just trying to mop up as much as I can. There was a point where I decided to stop the procedure because as I was peeling some dead keratin off the eardrum, the eardrum is visible, you'll see it. The eardrum flexed, so the suction was pulling the eardrum inside the ear canal towards the entrance, and that's for me at the point where let's just stop now. Sometimes less is more. That's what I've learned over the years. And my colleague, Mr. Darish Rajali, who's an ENT surgeon, we were having a chat a few weeks ago, and one of the things he's a consultant ENT surgeon who's got many years of experience, and he's found that over the years he's realised as well that less is more, that motto. So when he's performing ear surgery, sometimes if you try to be too cute and clever, you can cause more problems and more complications. And he said that's the hallmark of a good surgeon and a great surgeon. That's how you differentiate between the two. Is he's learned from watching some of the great surgeons that he's worked with that there's a point in the procedure to think, well, we've done enough now, and we continue to try and operate. It's not going to give the patient any significant additional benefit, but by attempting to do more, you could actually then cause more complications, and it's that fine line that he was explaining as surgeons they tread, and I suspect it applies to earwax removal as well. There's a point where we think that is enough. Otherwise we could be in the ear for forever, quite literally trying to remove every little aspect, and by doing that you're going to cause more injury and trauma. And of course when someone's eardrum flexes up, that's the kind of point where you think, we've done work there. I think you might have just seen it, the eardrum just flexes at that point. So I'm just going to mop up around the edge now a bit.
I'm going to leave it at that because
you could hear really
saw
well.
Your eardrum flex and I was inside your ear with the vacuum.
The
vacuum towards your eardrum kind of stuck inwards. So I'm going to leave that. I can see the eardrum and happy with that. I don't think for a minute I'll get as much out as I do. Or even get this far in your ear
as soon as possible, so they can get prescribed the right type of medication.
Just a little bit, it's not
they'll probably do a swab to confirm whether it's bacterial or fungal infection and what type of bacteria, what type of fungal, if it is that. In the meantime, because it's the weekend here now, I've recommended the patient to obtain some Earol. Earol is a over-the-counter ear spray. It contains acetic acid, so it's almost like a vinegary solution. And it's got an acidic pH, so if you've been watching my recent videos, I've been explaining that the ear should naturally be acidic. When it's infected like this gentleman's ear, it's a lot more alkaline. So to re-acidify the ear itself can help reduce the likelihood of, obviously can kill the infection and stop it from developing any further. So just a final view of the eardrum. Well, I hope you're all keeping well and safe, whichever part in the world you're watching this video from, and hopefully I'll upload a new video over the weekend. Take care guys, have a great evening, bye.